Welcome to the deep dive. Our mission today is, well, it's highly specialized and frankly, absolutely critical.
It really is.
We're going to be synthesizing the essential knowledge you need to master geriatric anesthesia.
Yes.
And this isn't just theory. This is about clinically safe, physiology-driven management that's framed for, the highest scoring answers.
Right.
Whether you're facing a 20-mark essay question, a short note on frailty, or those really crisp one-liners you need for a Viva.
Exactly. And we're approaching this not just as, teachers, but really as senior examiners.
Right.
We have to focus on the one fundamental truth that governs everything in geriatric care.
Which is?
The profound, and I mean profound, reduction in physiological reserve.
What's the key phrase?
It's everything. Every single change in management we discuss, whether it's drug choice or temperature control, it all stems directly from that single vulnerability. So we'll break down the physiology, the pharmacology that results from it, and then the critical prevention strategies.
So by the end of this deep dive, you'll have a really robust framework, something you can use immediately in the OR, but also something that gives you a tangible edge in any exam scenario.
That's the goal.
Okay, let's start at the very beginning. We need to define who we're even talking about. Who is the geriatric patient? Because chronological age, as we both know, can be a really misleading marker for risk.
That distinction is the absolute first point you need to nail down for an examiner. The difference between chronological age versus physiological age.
Right.
We tend to use an arbitrary cutoff, say 65 or 70, but all the literature, all the clinical practice, it overwhelmingly says that age alone is not a contraindication for surgery.
No, absolutely not. But the data is also crystal clear that morbidity and mortality, they're just significantly higher in this group. So why is that?
Well, it comes back to exactly what you said. It's not the number. It's two critical compounding factors. First, the high frequency and severity of coexisting medical conditions.
The comorbid.
Exactly. And second, and most importantly, that diminished functional reserve we just mentioned, that lack of a backup system.
So you could have an 85-year-old who runs marathons.
Exactly. An 85-year-old who's incredibly fit, low physiological age, versus a 65-year-old with coronary disease, diabetes, maybe some early frailty.
A completely different patient.
Their physiological ages are worlds apart. And the anesthetic risk, it tracks with the physiological age and the disease burden, not the date on their driver's license.
And this is not a niche topic anymore. I mean, the demographic shift we're seeing is massive.
Well, the epidemiology really underscores the urgency here. Projections show that the global population over 65 is set to nearly double by 2050.
Wow.
We're going from around 700 million to 1.5 billion people.
So every single anesthetist is going to be a geriatric anesthetist to some extent.
You have to be. This knowledge is becoming absolutely mandatory.
Okay, so if we understand the population and the risk, what are the core goals? If you're structuring a high-scoring answer, what's the why behind our choices?
Well, we have to move beyond just survival. I think there are three primary interconnected goals that really define success here.
Okay.
First, obviously, is safety. That's the foundation. It's always paramount.
Cool.
But the next two are what show a deeper understanding. The second is functional preservation.
Meaning what, exactly?
Meaning our aim isn't just to get the patient through the surgery. It's to return them to their cognitive and physical baseline.
And we measure that baseline with those functional metrics, right? The ADLs and IADLs.
Exactly. The activities of daily living, or ADLs, that's the basic self-care.
Yeah.
Bathing, dressing, feeding yourself.
Right.
And then the instrumental ADLs, the IADLs. These are the higher level tasks for independent living. Shopping, managing money, taking their own medications correctly.
And losing those is the real catastrophe we're trying to prevent.
That is the life-altering outcome.
Right.
The success of the surgery is really defined by the quality of life after recovery, not just surviving the procedure itself.
Okay, so safety, functional preservation. What's the third goal?
Rapid recovery.
Uh-huh.
This is so essential, and it's what drives the whole strategy of early mobilization.
Because keeping an older patient in bed is just, it's dangerous.
It's incredibly dangerous. You get a huge spike in the risk of DVT, pulmonary embolism, pneumonia. And on top of that, minimizing time in the recovery room, or ICU, minimizes their exposure to what are often very deliriogenic environments.
All the noise, the lights, the confusion.
Precisely. So every hour you gain in early mobilization is a massive clinical victory.
That sets the stage perfectly. The core challenge is that lack of a backup system. So let's drill down now into the specific physiological changes that get rid of that reserve. This is the absolute foundation for any high-scoring answer. Okay, let's unpack this. This is the high-yield stuff. Understanding the pathology and how it directly impacts our drug choices and techniques. Let's start with the big one, the cardiovascular system.
Right. The cardiovascular changes are, as I said, they're profound. They're structural. We see this decreased arterial elasticity, what we call arterial stiffening.
What's happening on a microscopic level?
Well, histologically, you're seeing things like hyperplasia, the intima, a lot of collagenization, and significant calcium buildup in the elastic fibers of the big vessels.
So the pipes are getting stiff, which means the pressure inside them has to go up.
Exactly. The systemic vascular resistance, the SVR, is permanently increased. So the afterload on the left ventricle is just, it's constantly high.
And the heart has to work against that.
Constantly. Which leads to two really critical structural changes: left ventricular hypertrophy, or LVH, and probably most importantly for us, diastolic dysfunction.
Ah, diastolic dysfunction. This is so key for managing fluids and heart rate, isn't it? The ventricle is stiff, so it can't fill properly?
It's hugely important. It accounts for almost half of all heart failure cases in this population. That stiff, non-compliant ventricle. It needs more time and more energy just to relax and allow for proper filling.
So anything that shortens diastole, like tachycardia,
Is catastrophic. Tachycardia is the enemy here. It can just completely impair ventricular filling, and you can get rapid, hard-to-treat hypotension. Or, if you overload them with fluid, you can tip them into flash pulmonary edema.
Okay, now let's talk about the control system, the autonomic nervous system, which is supposed to keep things stable but really starts to fail in older patients.
Yeah, what's fascinating here is the differential response. You get this marked reduction in beta-adrenergic receptor sensitivity. We call it beta-receptor blunting.
The heart just doesn't respond to adrenaline the same way?
It can't. It can't speed up or increase contractility as effectively. But, and this is the crucial part for our pharmacology, the peripheral alpha response is largely retained.
Okay, so the beta is blunted, but the alpha is okay.
Exactly. And you couple that with a severely impaired baroreflex. That's the reflex that should compensate for blood pressure drops.
Yeah.
And you have a cardiovascular system that's just, it's underdamped. It cannot effectively buffer any stressor, whether that's a drug or a blood loss.
So classic scenario. You give your induction agent or the spinal kicks in, blood pressure drops, and the heart just can't speed up to compensate.
That is the absolute classic scenario.
Yeah.
And because that beta response is blunted, a drug like ephedrine, which is a mixed alpha and beta agonist, becomes much less effective.
So for the exam, you need to show you know how to get around that blunted response.
You do. The preferred drug choice for managing that acute hypotension is a selective alpha agonist.
Like metaraminol.
Metaraminol or phenylphrein. You're relying almost entirely on that retained alpha response to squeeze the peripheral vessels and raise the blood pressure without trying to flog a dead horse, so to speak, with the blunted beta receptors.
Okay, that makes perfect sense. Let's move to the respiratory system. You mentioned this is a combination of both restrictive and obstructive changes.
It really is a double whammy. You get restrictive changes from the chest wall itself getting stiff and calcified, making it physically harder to expand.
Right.
And then you get obstructive changes because the lungs lose their elastic recoil, so the small airways tend to collapse prematurely. It's almost like a mild emphysema.
And this has a very specific high-yield effect on lung volumes, doesn't it?
It absolutely does. The functional residual capacity, or FRC, and the residual volume both increase. But here's the critical physiological detail that examiners love to see.
Okay.
With aging, the closing capacity, or CC, starts to exceed the FRC.
And that happens much earlier than people think.
It happens by about age 45 when you're lying supine.
45. So this isn't just an issue for the very elderly?
Not at all. And by 65, the closing capacity exceeds FRC even when you're sitting up.
So what does that mean clinically?
It means that during normal, quiet breathing, small airways are collapsing, trapping gas, especially in the dependent parts of the lung.
Creating VQ mismatch.
A huge VQ mismatch. And a significant shunt. It just torpedoes your gas exchange efficiency.
Which means you absolutely need to pre-oxygenate properly. You need to give supplemental afterwards. And it explains why the inhalational agents take longer to wash out.
Precisely. And don't forget the airway itself. The muscles in the pharynx and larynx get weaker, so you lose that support.
Yeah.
That means a much higher risk of upper airway obstruction and aspiration, especially during induction or emergence.
Right. Okay, the central nervous system. This is so central to the biggest complication we see. Postoperative neurocognitive disorders. What are the key physiological changes here?
Well, you see a measurable physical decline. Brain mass can shrink by up to 20% by age 80.
20%.
And with that, You get a proportional drop in cerebral blood flow and oxygen consumption. But critically, you get this depletion of key neurotransmitters. Dopamine, norepinephrine, serotonin, and especially acetylcholine.
And that depletion is the direct link to why our anesthetic drugs are so much more potent.
It's the absolute foundation for the most critical pharmacological implication: increased pharmacodynamic sensitivity. The aged brain is just profoundly more responsive to even tiny doses of our drugs. It's the single most vulnerable target for PNDs.
Okay, let's talk about the organs that get rid of the drugs, the renal and hepatic systems.
In the kidneys, you just see this progressive decline in everything: renal mass, blood flow, GFR. But here is the classic trap for both clinicians and examiners.
Let me guess. Serum creatinine.
Serum creatinine. It is a notoriously poor indicator of GFR in the elderly.
And you need to be able to explain exactly why that is.
You do. Creatinine is a byproduct of muscle metabolism. Older patients have less muscle mass. So a normal creatinine in an 80-year-old can hide a GFR that's 50% or less of what it should be.
So you're almost guaranteed to overdose drugs if you just trust that number.
You will. You have to use an equation that accounts for age, like the Cockcroft-Gault, to estimate the real clearance. And remember, their ability to handle salt and water is also impaired, so the window for fluid management is perilously narrow.
And the liver follows a similar path.
A very similar trajectory, yes. Liver blood flow can be reduced by up to 40% by age 80. Liver volume shrinks. This all means reduced hepatic clearance, especially for those phase-I metabolism reactions.
So any drug that relies on the liver or kidneys for clearance is going to hang around for a lot longer.
A lot longer. And it can be unpredictable. This is why we might favor agents that are cleared independently of major organs, like cisatracurium.
Finally, just to round this section out, a quick word on thermoregulation.
It's simple but vital. They can't generate heat as well, and they lose it more easily. They are incredibly susceptible to hypothermia, so aggressive, proactive temperature management, strict normothermia is absolutely mandatory. It's not optional.
Okay, we've laid that physiological groundwork. Now for the most direct clinical consequence, pharmacology, the logic of dose reduction. This is mandatory knowledge, and we have to frame it around pharmacokinetics and pharmacodynamics.
Right, what the body does to the drug and what the drug does to the body. You have to trace the drug's journey through the aged system.
Let's start with distribution. The body composition changes. How does that specifically affect our IV agents?
The body composition changes are the first major hit. You have less lean body mass, less total body water, but a lot more body fat.
Okay.
So think of the water and muscle as the central compartment. That's where the IV induction agent lands first.
And that compartment is smaller.
It's much smaller. So for a standard unadjusted dose, the peak plasma concentration in that central compartment, and therefore in the brain, is immediately much, much higher.
An instant overdose, essentially.
It's a transient, intense overdose effect. You have to sharply reduce that initial bolus dose. It's non-negotiable.
And then the flip side of that is the increased body fat. For lipid-soluble drugs, that acts as a huge reservoir, right?
That is the critical second hit. That increase in body fat acts as a massive reservoir that just soaks up drugs like our volatile agents or diazepam. It leads to this prolonged terminal half-life because the drug accumulates and then leaches out very, very slowly.
So a single overdose or a prolonged infusion can lead to days of sedation.
Absolutely. So you have this combination: a faster and more intense onset from the smaller central compartment and a much longer, slower offset because of the fat reservoir and the slower clearance we just talked about.
Okay, so that's the pharmacokinetics. What about pharmacodynamics? Is the brain itself just more sensitive?
It is absolutely more sensitive. That's the PD change.
Yeah.
And we can actually quantify it with the minimum alveolar concentration, or MAC.
The famous rule.
The simplest, most universally applicable rule we have. MA declines linearly by approximately 6% per decade after the age of 30.
6% per decade. That is the concrete, high-scoring fact you have to know.
It is. It perfectly demonstrates that intrinsic CNS sensitivity. The aged brain is just more susceptible to our anesthetic agents.
So let's get really practical. Dose adjustment principles for specific drugs. We need some concrete numbers here for the exam.
The overarching rule is always, start low and titrate slow.
And the titrate slow part is just as important as the start low part.
It's vital. Because cardiac output is often reduced, the arm-brain circulation time is longer.
Right.
If you push a drug too quickly, even a reduced dose, it can arrive at the brain in this delayed but still massive bolus, causing profound hypotension before you even have a chance to react. Slow injection compensates for that slow circulation.
Okay, let's go through the main classes. Induction agents.
Right. Propofol and thiopandol. You have to reduce them significantly. Thiopandol by about 15%, but propofol needs a 30 to 50% reduction.
30 to 50. That's huge.
It is. And studies have shown that propofol doses over 1.5 milligrams per kilogram are significantly associated with severe hypotension in the elderly. That's a real danger threshold.
Okay, what about opioids and sedatives?
Again, the CNS sensitivity is just dramatically increased. Midazolam requirements are typically half, and its half-life is much longer. For opioids, it's stark. Even for something ultra-short-acting like remifentanil, an 80-year-old might need a 55% dose reduction compared to a 20-year-old for the same effect.
Wow, and that's almost purely a pharmacodynamic change.
It's almost all increased brain sensitivity.
And muscle relaxants.
Well, anything that relies on the liver or kidneys for clearance, so pancuronium, vecuronium, rocuronium, their duration of action is significantly prolonged.
So non-organ-dependent drugs like atracurium or cisatracurium are a better choice?
They can be favorable, yes. But even with those, you must use objective neuromuscular monitoring to ensure complete reversal. Residual block is a massive risk for postoperative respiratory problems.
And local anesthetics for regional.
The dose has to come down there too. The epidural space is smaller, there's less CSF, so the local anesthetic tends to spread higher and faster. You have to reduce the dose to avoid an excessively high block and profound hypotension.
The quality of what happens in the operating room is really decided before the patient even gets there. This section on preoperative assessment and optimization is just essential, especially the modern focus on frailty.
Absolutely. The preoperative clinic isn't just about listing diseases. It's about trying to establish the patient's functional reserve.
Across all the major organ systems.
Heart, lungs, CNS, kidneys, liver. That's the whole point of the Comprehensive Geriatric Assessment, or CGA.
So how do we actually do that in a busy clinic? What are the simple but powerful tools?
Well, you have to go beyond just asking about their past medical history.
Right.
You have to rigorously assess their functional status with the ADLs and IADLs we talked about, and the history itself is a powerful tool.
How so?
Asking about their ability to handle mild stress. Can they climb a flight of stairs without getting severely short of breath? If they can't, that tells you their reserve is gone. And you absolutely must get a collateral history from a family member.
Especially for cognitive function.
Especially for cognition. The patient may not be aware of their deficits, or they might try to hide them.
Okay, the hottest topic here is frailty screening. We have to define frailty clearly and explain how it's different from just having a lot of comorbidities.
Right, that's the key distinction. Frailty is a state of increased vulnerability to stressors. It means a minor event can cause a disproportionately bad outcome. It is a powerful, independent predictor of bad outcomes, often more powerful than the ASA score.
And it's very common.
Extremely. Up to half of older surgical patients might meet the criteria for frailty, so you have to screen for it.
What are the best tools for that, the high-yield ones?
The most practical one is probably the Clinical Frailty Scale, or CFS. It's very quick, takes less than a minute, and a score of 4 or more strongly correlates with poor outcomes. Another one is the Fried Phenotype, which looks at 5 specific physical things like weight loss, exhaustion, and grip strength.
And the really important thing about frailty is that it might be modifiable, which brings us to prehabilitation.
Exactly. Frailty isn't necessarily a fixed state. Prehabilitation, which is basically a program of nutrition, physical exercise, and even cognitive exercise before surgery, is this emerging strategy to try and boost that reserve before the stress of the operation. It's a really exciting area.
Now, since cognitive impairment is the #1 risk factor for PNDs, what are the mandatory screening steps there?
Every single patient should be screened. The mini-cog test is a great, quick tool. It combines a 3-item recall with a clock drawing test. But again, you cannot rely only on the patient. Collateral history is vital to establish their true baseline.
And what are the simple, high-impact things we can do to optimize them and hopefully prevent delirium?
The simplest, most effective things are about minimizing sensory deprivation. You have to tell them, bring your glasses, bring your hearing aids, bring your dentures to the hospital, and make sure they are actually used right after surgery.
Right.
And second, you have to meticulously review their medication list and stop any potentially deliriogenic drugs. Anticholinergics, benzodiazepines if you can, and absolutely no meperidine.
Which brings us to the huge issue of polypharmacy.
It's the rule, not the exception. Most older patients are on 5 or more medications, and the risk of drug interactions is just astronomical. You have to get a detailed history, looking for things that might subtly alter anesthesia, like H2 blockers affecting liver enzymes.
And you have to pay attention to specific comorbidities that really constrain your anesthetic choices.
Absolutely. Severe aortic stenosis, for example, makes a spinal anesthetic incredibly risky because those patients can't tolerate a drop in SVR. Or severe degenerative spine disease might make regional techniques technically impossible. Optimization is about identifying these specific risks ahead of time and having a plan A, B, and C.
Okay, let's step into the OR. The big debate always is general anesthesia versus regional anesthesia. What does the evidence actually say about which one is better for the elderly?
Well, the controversy exists because there is no single best answer. That's the key takeaway.
Right.
High-level studies have shown that for long-term outcomes like survival or major morbidity like a heart attack, there's no significant difference between GA and RA.
So the choice has to be individualized.
It has to be. It's dictated entirely by the patient's specific comorbidities, their functional status, and what the surgeon actually needs to do.
But regional must have some specific advantages, right? Especially for something like a hip fracture. What are the key Viva points in favor of RA?
It definitely has specific short-term advantages. The biggest one, especially for lower limb surgery, is a reduced incidence of DVT and pulmonary embolism.
And that's a huge deal in this population.
It's a critical differentiation point. Regional techniques also tend to preserve respiratory function and the cough reflex better, and maybe, just maybe, they reduce the incidence of that very early postoperative confusion.
Okay, what about the downsides? What are the challenges of doing regional in an older patient?
The challenges are mainly technical and hemodynamic. Technically, just positioning a patient with a broken hip or severe arthritis can be incredibly difficult, and their landmarks can be hard to find.
And hemodynamically?
The risk of profound hypotension from the sympathectomy is very real. And in that underdamped patient with stiff arteries, that drop in blood pressure can be catastrophic, especially if they have underlying aortic stenosis.
If we do choose a neuraxial block, are there anatomical changes we need to account for?
Yes, the anatomy is different. The epidural space is smaller, there's less CSF, and the dura might be more permeable.
So the block spreads further and faster?
Exactly. The onset is more rapid and intense, and it tends to go higher.
Which means dose reduction for spinal is non-negotiable.
Absolutely. You have to use a low dose, maybe 10 milligrams or less of bupivacaine, or even consider a unilateral spinal technique to try and limit the spread and minimize that hypotension.
And what about combining techniques? A light GA with an epidural for pain control?
You just have to be incredibly careful. The synergistic hemodynamic effects, the cardiac depression from the GA, plus the sympathetic blockade from the regional, can cause severe and really refractory hypotension. You need to be extremely vigilant.
Airway management also presents its own unique set of challenges in the aging patient. What are the key things we need to anticipate?
There are a few big ones. Degenerative cervical spine disease can really limit neck extension, making laryngoscopy difficult.
Right, the classic C-spine.
Then there's dentition. You have loose teeth, or more often dentures, which you have to remove, but that can then make getting a good mask seal for ventilation much harder. And as we said before, the loss of pharyngeal muscle tone just increases the risk of obstruction after you extubate. Aspiration risk is high across the board.
Okay, let's switch to intraoperative vigilance. Beyond the standard checks, what are the modern critical points for monitoring that we need to be focused on?
Well, beyond the basics, objective neuromuscular monitoring is absolutely essential. You have to confirm a TOF ratio greater than 0.9 to make sure you completely reverse the muscle relaxants.
But the really big modern focus is on neurocognitive protection, right?
That's where the field is moving. It's about meticulously titrating your anesthetic depth.
And how do we do that?
Well, you should consider using EEG monitoring, like a BIS monitor, to avoid periods of very deep anesthesia. We know that deep anesthesia, and especially burst suppression patterns on the EEG, are linked to higher rates of postoperative delirium.
So the goal is light, stable, titrated anesthesia.
Using that 6% per decade MSE reduction rule as your guide.
Okay, and hemodynamics. We've established metaraminol is our go-to for hypotension. What are our blood pressure targets?
We have to keep them in a very narrow range. The goal is to avoid hypotension, which starves the brain and heart of oxygen, but also to avoid hypertension and tachycardia, which massively increase myocardial oxygen demand.
So a rule of thumb.
A good general target is to keep their mean arterial pressure within 20% of their baseline reading. Use small, frequent, proactive doses of your vasoactive drugs.
Finally, the basics that often get forgotten, temperature and fluids.
Strict normothermia, non-negotiable. Use forced air warmers, fluid warmers, everything you have. Hypothermia is a known modifiable risk factor for bad outcome.
And fluids.
Extreme caution. Because of that diastolic dysfunction and poor renal reserve, it is so easy to fluid overload them and tip them into congestive heart failure. You need careful, goal-directed fluid therapy, not just pouring in liters based on some formula.
The job isn't over when the surgery ends. The postoperative period is often the most dangerous time, especially because of neurocognitive complications. We have to clearly define for the examiner postoperative delirium, POD, and postoperative cognitive dysfunction, POCD.
This distinction is a cornerstone of a high-scoring answer. Delirium, POD, is an acute disturbance. It's a change in consciousness and attention that develops over a short period, hours to days, and this is the key, it fluctuates.
It comes and goes.
Exactly. It's typically in the immediate postoperative period, and it's often reversible.
And POCD is different.
POCD is a longer-term cognitive decline. It's more subtle. Impaired memory, poor concentration that persists beyond that immediate recovery period, usually defined as lasting longer than 3 months. POD is the acute fire. POCD is the lingering smoke damage.
And the incidence rates for POD are just staggering.
They're enormous. It's the most common surgical complication in this group. It affects anywhere from 5 to 50% of older patients, and even higher after something like a hip fracture. And POCD affects 10 to 15% of patients over 60 for up to 3 months. It's a huge long-term problem.
So what are the critical risk factors we have to recognize immediately?
The big predisposing factors are age over 65, and number one with a bullet, pre-existing cognitive impairment or dementia. That is the most powerful predictor.
Right.
Other things like poor vision or hearing, frailty, severe illness. And then there are precipitating factors, the things we can often control. Using deliriogenic drugs, poor sleep, immobility, electrolyte problems.
So prevention has to be the main focus. What's the cornerstone of delirium prevention?
It's on pharmacological strategies. That is the gold standard answer.
The delirium prevention bundle.
Exactly. It's a multidisciplinary approach. You make sure their glasses and hearing aids are on, you reorient them frequently, you optimize their hydration and nutrition, you get their pain under control, you protect their sleep. And most importantly, early mobilization. Get them up and moving.
When do we reach for drugs then?
Only when the non-pharmacological methods fail and the patient is severely agitated and a risk to themselves or others. The preferred drug is usually low-dose haloperidol. You have to use things like lorazepam very, very cautiously and absolutely avoid anything with anticholinergic properties.
Beyond the brain, what about other high-risk complications?
DVT and PE are still a huge risk because of immobility. It's a common cause of postoperative death. And on the cardiac side, things like new-onset atrial fibrillation or hypotension can lead to delayed strokes, sometimes days after the surgery.
Okay, let's wrap this section up with pain management. Opioids are obviously dangerous.
They are. So pain management must be based on a multimodal analgesia approach. You want to maximize your opioid-sparing strategies because the respiratory depressant effects of opioids are so exaggerated in this population.
Which again makes the case for using regional techniques for postoperative pain?
Absolutely. An epidural or a peripheral nerve block can provide amazing pain relief and dramatically reduce the need for systemic opioids. But you have to be extremely cautious with NSAIDs.
Because of the kidneys.
The aged kidney is very vulnerable. NSAIDs carry a much higher risk of GI bleeds and acute renal failure. If you use them at all, it has to be for a short duration with very careful monitoring.
Okay, we've covered the whole spectrum. Let's synthesize this now into those high-level integrated answers that an examiner is really looking for.
Right, let's start with a direct comparison. Young adult versus geriatric patient. This forces you to link everything together.
Okay, I'll give you the category, you give me the key geriatric alteration. MAC requirement.
Reduced by a linear rate of 6% per decade after age 30.
Dose requirement for IV induction agents.
Significantly reduced, 30–50% for propofol. And you have to titrate it slowly because of the smaller central compartment and longer circulation time.
Beta adrenergic response.
Wanted, which leads to a clinical preference for pure alpha agonists like metaraminol for hypotension.
And drug elimination half-life.
Prolonged, due to the bigger fat reservoir and the slower kidney and liver clearance.
Perfect. Now let's tackle that GA versus regional debate for a hip fracture again. What's the nuanced, expert answer that gets you the highest marks?
The nuanced answer is that while overall mortality might be similar, Regional anesthesia offers the specific demonstrable benefit of reducing DVT and PE.
And that's a high-risk complication in this specific group.
It's the crucial differentiation point. You can also add that RA may preserve respiratory function better in the immediate postoperative period.
Okay, let's do some rapid-fire examiner traps. Explain the dose reduction logic to me in one crisp sentence.
Dose reduction for IV agents is needed because of a reduced central compartment volume, which is a pharmacokinetic change, and increased CNS sensitivity, which is a pharmacodynamic change.
Excellent. Okay, crap number 1. Is general anesthesia contraindicated in the elderly?
The safe response is no, age itself is not a contraindication. High risk correlates with coexisting disease, frailty, and diminished physiological reserve, not age alone. Management focuses on optimizing that reserve.
The key phrase on neurocognitive risk.
The most consistent and powerful risk factor for perioperative neurocognitive disorders is advanced age combined with pre-existing cognitive impairment.
Okay, finally, let's distill this into some last-day revision tools. First, a geriatric anesthesia management algorithm.
It has to follow a preventative pathway. It starts with a comprehensive geriatric assessment, the CGA. That leads directly to frailty and cognition screening. Then you optimize, including prehabilitation. Intraoperatively, you minimize your anesthetic depth or your vasoactive drug use, and postoperatively, you implement the delirium prevention bundle.
And last thing, a 3-point Viva safety checklist. The 3 absolute non-negotiables.
1. Complete neuromuscular reversal, verified with objective monitoring. 2. Strict normothermia, maintained throughout. And 3. Early sensory input and orientation. Get those glasses and hearing aids on immediately.
We have unpacked so much. I mean, the whole clinical challenge really does boil down to managing a patient whose systems are just operating right on the edge of compensation.
And our job is to use precise, titrated care to keep them as far from that edge as possible.
And that really underscores why that detailed functional assessment of reserve is the most valuable thing you can do.
Absolutely. Remember the 3 pillars of success: understanding the reduction in reserve, implementing clear dose reduction logic, and just obsessive vigilance against those postoperative neurocognitive threats.
Okay, here is a final provocative thought for you to take away. Given that we now recognize frailty as a potentially modifiable risk factor, and we know that a frailty score can be a more powerful predictor of mortality than the standard ASA score, how should this change our medical, legal, and ethical responsibility for surgical consent? If we can measure frailty and potentially improve it, should we now be required to formally screen for it, disclose that specific risk, and offer optimization before we even proceed with elective surgery? It's a challenge that I think will really define perioperative medicine in the coming decade.